On behalf of the American Kidney Fund, we're thrilled to have you join in. My name is Mike Spigler, and I'm the Vice President of Patient Support and Education at the American Kidney Fund, and I have the honor of acting as your moderator during this interactive session all about kidney stones, causes, types, treatment, and prevention. Kidney stones are a common problem affecting over 500,000 people every year, and 1 in 10 people will have a kidney stone at some point in their lives. In today's session, our panelists will give an overview of what a kidney stone is, its signs and symptoms, and what are some common risk factors. And they'll also discuss the multiple types of stones and how finding out which type of stone you have may help improve your treatment and prevention options. Before you get started, I want to encourage everyone to join the conversation wherever you may be logging in from today. We'll have a very brief Q&A at the end of our time today, but you don't have to wait to submit your questions now. You can drop your comments in the window next to or below the Facebook live stream, or the chat box right next to it if you're here with us on the KAW website, and we'll try to get to as many as possible. I want to take a minute to thank our session sponsor for whom this would not be possible without. So I want to thank Alnylam for their support, not only in this project, but for others, and greatly appreciate their partnership efforts to bring information about kidney stones to the public. So now let me introduce our experts for today's session. This afternoon, I have the pleasure of joining me, Dr. David Sass, Dr. John Liskey, Kim Hollander, Jamie Schmidt, and Leanne Saylor, who will provide their insights on this very important topic. Just quickly go through everyone's bios. I would first like to introduce Dr. David Sass. Dr. Sass is a pediatric nephrologist at Mayo Clinic who specializes in urinary stone disease, especially rare genetic forms of urinary stone disease. At Mayo Clinic, he is also the co-director of the Renal Laboratory, co-director of Pediatric Program in the Department of Laboratory Medicine, director of Patient Experience for Pediatrics, and director of the Patient and Family Advisory Council. In 2014, he joined the faculty at Mayo Clinic and further established his expertise in urinary stone disease and genetics. Next is Dr. John Liskey. Dr. Liskey is a nephrologist and professor of medicine at Mayo Clinic in Rochester, Minnesota. He has a long-standing interest in urinary stone disease and the evaluation of kidney function. And over the last decade, he has completed clinical trials evaluating the effect of diet, probiotics, phosphate binders, and other factors on urinary stone disease patients. Next, I'd like to introduce Kim Hollander. Kim has a track record of success in orphan disease that spans over 20+ years of leadership. As executive director of the Oxalosis and Hyperoxaluria Foundation, she is responsible for driving the vision, strategy, and innovative thinking, as well as overseeing daily operations. She specializes in research strategies and building relationships with advocacy groups, regulatory agencies, biotech, professional and patient communities to improve the care and treatment for all forms of hyperoxaluria. Next is Jamie Lynn Schmidt. Jamie is parent advisor of the Oxalosis and Hyperoxaluria Foundation. She is the parent of 2 sons with primary hyperoxaluria type 2. She works to drive engagement, conversation, and improvements to treatments surrounding all things hyperoxaluria. And last but certainly not least is Leanne Saylor. Leanne grew up in the Louisville, Kentucky area, and while attending the University of Louisville, she met her husband, Michael. In 2009, Mike was diagnosed with ESRD at 42 years old and given 5 to 10 years to live on dialysis. She took Mike to the Mayo Clinic where she learned, where she found that a transplant would save his life and keep him off dialysis. Leanne is a public speaker and educates on the importance of living donors across the country. She was awarded the prestigious Bell Award by WLKY in the Spirit of Louisville. She is an ambassador for the American Kidney Fund, a coach for the National Kidney Registry, and has received the Commission of Kentucky Colonel, the highest title of honor bestowed by the Governor of Kentucky. Thanks to all of you for being here. So Dr. Liskey, we will start the session with you and give our audience an overview of kidney stones.
Great, thank you very much. I'm very glad to be here this afternoon to talk a little bit about kidney stones, give you an overview. So if I can have my first slide, please. So I'm going to go over what are kidney stones, why do people get kidney stones, and then a little bit about the genetics of kidney stone disease. So next slide. So why do we care about kidney stones? Well, they're certainly very painful. So anyone that's ever had one would tell us that it's sometimes the worst thing they've ever had happen to them in their life. And they're very common. So it's like something like 10% of men and maybe an equal number of women that might get a kidney stone in their lifetime. So that's 1 out of 10. That's a lot. They often recur, so people don't have just one bout, but many bouts over their lifetime. And they're very costly. This is an old number. It's actually more like $10 to $15 billion a year spent on treating people for kidney stones. And they have to have things like go in the hospital, cystoscopy, or other kinds of surgery to remove the kidney stones. So next slide. There's a couple examples. So the kidney stone that you might pass or have removed is in somebody's hand down there on the bottom. But they start out as little crystals in the urine, which is shown above there. So that's a picture of somebody's urine with calcium oxalate crystals. They can deposit anywhere. Once they form in the kidney themselves, it's really no pain associated with that. But once they break off, that's when they block the ureter anywhere along the way, and that's when people have a lot of pain with them. And over there's just an x-ray of somebody with a rather large kidney stone that's pretty obvious. So next one. So what kind of stones do people make? Up there in red, so most are going to be either calcium oxalate, a majority, or apatite, which is a kind of calcium phosphate, and that's about 80 to 85% of all stones. So that's the lion's share. Less common would be things like uric acid, 8 to 10%. Struvite is an infection stone, and then anything other than that becomes quite rare. Next slide. The key concept for when we see people with kidney stones is understanding supersaturation. So these are 3 test tubes of urine, and we're dropping a crystal of, say, calcium oxalate into the urine. If it's right at saturation, that would be, the crystal would neither grow nor dissolve. If it's supersaturated, it would tend to get bigger. If it's undersaturated, it would tend to dissolve. And at least a lot of why people get kidney stones has to do with this supersaturation, that their urine is overly concentrated to grow things that can make kidney stones like calcium oxalate. We don't actually measure this in the clinic by dropping crystals into urine, but rather there's a computer program that turns the numbers from a measured 24-hour urine, things for like calcium and oxalate, into this predicted supersaturation. And that's what we use a lot to manage patients. Next. So why do they form? Well, certainly urine is supersaturated. So it turns out for calcium oxalate, almost everybody is supersaturated a lot of the time. But people that get kidney stones tend to be more supersaturated. We know that there's other biology to it that's not fully understood. It's an area of active research understanding why some people get stones and some people don't. But the supersaturation, we know a lot about that, and that's what we measure in clinic, and that's what we try to address with a combination of diets and medications. The kind of supersaturation, so it's either calcium oxalate, calcium phosphate, that does actually correlate very well with the type of stone someone might make and also your risk of having more stones. So really what we do a lot in clinic is try to figure out why you might be saturated and then try to address that with diet and medications. So next. So when we do this, we typically get a 24-hour urine. The things that we might measure are shown here. There's about 13 different substances that go into a 24-hour urine. We also get a creatinine on this to understand if you did a good job collecting the urine. And then these are the things that go into that equal to program to predict the saturation. But then we also are looking at each of those individual factors, like the volume, like the calcium, like the oxalate, because understanding exactly why you might be supersaturated is also important, and the treatment might depend a lot on what exactly we find there. So, for example, if it was hyperoxaluria, we might treat that differently than hypercalciuria. Next. So here's just a summary of some of the common risk factors. So hypercalciuria, high calcium in the urine, this is often a familial genetic thing. There are some specific things like overactive parathyroids that can cause it. We would treat that with a low salt diet, perhaps low protein, or at least lower protein, and then a certain kind of diuretics, thiazides, might be useful for driving that number down. Hyperoxaluria, high oxalate in the urine, sometimes this is dietary, sometimes it's due to GI conditions that cause fat malabsorption, and more rarely it's due to genetics. You're going to hear a lot about that later. If it's in regular stone clinic, we're going to think about a low oxalate diet, low fat diet, perhaps give people calcium supplements to bind up the oxalate. Low citrate in the urine. This is often due to diet. If your diet is relatively more meats and protein and less fruits and vegetables, or patients that are losing it through diarrhea for some reason. If it's a dietary issue, perhaps if we get you on a healthier diet, that will help. Certain fruit juices have a lot more citrate in it, and potassium citrate can be given as a medication. high uric acid in the urine. This is often diet. Again, this is high protein diet, so we would try to get you on a lower protein diet. And then there are medications that can block uric acid production. And finally, low urinary volume. This will be bad for any kind of stones. If you're not drinking as much fluid, you're going to be more concentrated. So this is related to job and environment sometimes. So we try to figure out why you might not be drinking as much fluid and then try to correct that. Next slide. There are also rare genetic causes that we have studied a lot at Mayo Clinic over the years, including these 4 listed here. Next slide. So when might we suspect one of these rare causes? Well, certain things, features of the patient, which are listed on this slide, might make us think it's more likely one of these rare genetic causes that can cause not only kidney stones, but kidney failure. So having your first stone when you're very young, having some sort of kidney failure that makes you go in the hospital, having a strong family history, some other associated findings like decreased hearing goes with certain rare causes. Those are things we might key in on. As far as on the imaging, having nephrocalcinosis, this is where you don't have just a single stone or a couple stones, but actually there's a lot of calcium in the kidney. That's a tip off that there might be something going on, or just having many, many stones, more than a couple, that might make it more likely one of these genetic things. Anytime there's kidney failure or reduced kidney function, we have to think, is it one of these genetic diseases? On the urinalysis, if there are specific crystals, there are a couple forms that point to one of these rare genetic things, such as cysteine crystals or these dihydroxyadenine crystals. Those are always abnormal. In the stone analysis as well, it's always important to send every kidney stone for analysis. So if it has dihydroxyadenine or cysteine, we can make that diagnosis from that alone. And then finally, in those 24-hour urines, there are some features that will point us to one of these. Very high oxalate will suggest perhaps primary hyperoxaluria. We have to specifically look for cysteine. That's not on the routine panel, but if we screen for it, it will be very high and we'll make that diagnosis. And again, if we are suspecting dihydroxyadenine deficiency, then we have to send out for a special test for that. And then there's another rare genetic cause called dent disease that affects men because it's X-linked. In that case, we see a lot of protein in the urine, and that's a tip-off to that. Okay, next. So key takeaways are that kidney stones are common. They are associated with a lot of patient morbidity and medical expense. There are treatments to decrease the risk of recurrent stones, and there are rare genetic causes of kidney stones that it's very important to find out, to diagnose them, and then get people on the right treatment. And with that, I'll turn it back to Mike.
Thank you, Dr. Liskey. And just a question for you. You mentioned, frequent stones being more than a couple. Is that the number? Is there a number that a patient should be thinking about as far as I really should get this checked out?
Well, I think it's a little individual, but certainly more than one. I think it's worth a workup because then you've declared that you're likely going to be a recurrent stone former and might benefit from treatments. But certainly, if you get 2, 3, 4, 5, the more there is an indication to work it up.
Great. Well, thank you. We've got a large panel, so I'll keep us moving. I want to now bring in Leanne Saylor, and she is going to talk a little bit about her experience as a caregiver for her husband, Michael. As I mentioned her bio, but through that process, she discovered her own kind of kidney stone journey. So Leanne, I'd love to bring you in and have you talk a little bit about your story.
Thank you, Mike, for having me. As Mike probably knows, I feel like our last name should be Kidney because our family is bombed with just about every facet of it. It was when my husband needed a kidney transplant that I learned a lot more about my kidney stones. However, I grew up thinking that was just normal to have stones because my mother and my grandmother would lay on the floor quite frequently in horrible pain. So I kind of just thought it was going to be in my future. Didn't realize, anything about the symptoms and what was happening to me that I was looking for. But I will say that when I was 24, I felt like I was having a bladder infection. I had that twinge, the pain and the frequency to urinate feeling. Just thought it was a bladder infection. I woke up in the middle of the night in the worst pain I've ever felt in my life. I've had 3 children. At that time, I'd only had 2, but I would take giving birth without anything for labor pains rather than a kidney stone. Fast forward, I've probably had about 5 of them. going into getting my husband worked up for a transplant. But I'm sorry to admit, any doctors that are on here, but I was desperate to save my husband. So I lied about my kidney stones, told him I'd only ever had one because they said there was a possibility I could be his donor. But not only did I get caught that I'm a kidney stone producer, but I had 5 more of them up in there that I knew was going to have to pass. That being said, my 3 boys, my oldest one and my middle one, passed their first ones in high school. One of them never missed a single football practice while he was doing it. I couldn't figure out for the life of me how he did that, but I have learned there's different sizes of stones. My first one was too big. I would not have been able to pass it. They had to do what's called a cystoscope to go and get it. I don't really know much about, exactly what all that entailed because it was 25, 30 years ago, but I have had several more cystoscopes. I've been able to pass a few stones. There are some that you just feel a little twinge. It's not that bad. Unfortunately, in my family, it basically drops us to the floor. I have to basically get to the ER right away, and I walk in and I tell them I'm having a kidney stone. I got to have something for pain, and then I'll talk to you. But, really there's really no one symptom that I can tell you because it was a lot of things that added into it. Now, my oldest son, he has something they call thin basement membrane syndrome with his stones, meaning when he does pass stones, the blood in his urine is scary. It looks like Coca-Cola. I never passed blood with mine. So there's different, kidney stones are really kind of hard in the beginning unless you're getting the pain to be able to diagnose. From what I say, one of the doctors can, jump in here. I do know they dissected all mine or did biopsies, and they were the calcium oxalate. What do I do to try to prevent them? I drink a lot of water. A lot of times I'm not real good about that, but it does, it, of course, makes your urine flow a lot better, and it decreases the fact that the calcium will build up in your urine. The other thing I do is I don't add any salt to my food at all unless I absolutely have to have it. They put me on a low sodium diet many years ago, and I just try to maintain it that way. I do know that I'm going to have these for the rest of my life, and my children are too. But, it's something that I guess I've just faced. I'm going to have the pain different times in my life, but hopefully I can answer any questions that anybody has, and the American Kidney Fund knows how to get in touch with me. I'm just one of the unlucky ones that is going to produce stones for the rest of my life.
Well, Leanne, you and your family have been through a lot, and we've talked to you. You're right. I mean, your last name being kidney, because I think you've been in about 3 or 4 or 5 different kinds of sessions we've talked about because of everything you experienced. Who do you usually see from like a doctor perspective? Is it primary care, urologist, nephrologist? Who are you going to see usually about your stones?
That is another thing I wanted to say. I'm glad you asked me that, because when I was first diagnosed, they sent me to a urologist. Obviously, he was the one that was on call and came in and did my cystoscope. Really didn't explain it as much to me about the seriousness of what could be coming in my future. Now that I know so much about kidneys, obviously we've been to Mayo Clinic. I work with a lot of the nephrologists. I really feel like they should have sent me to a nephrologist in the beginning, because I think they could have probably put me on the right track a lot better, how to keep these from recurring. But I don't know the protocol, if they do that now or not, if it's still a urologist. But I never learned that kidney stones were considered stage 1 kidney disease until the Mayo Clinic told me 30 years after I'd had my first stone. So I don't know what they weigh that out on, why they sent me to a urologist rather than a nephrologist, but I would have liked to have gone to one.
Great. Well, thank you very much for sharing your story, Leanne. We're going to keep things moving and now move to talk about a rare condition that can cause multiple kidney stones and really negatively impact your kidney health. And Dr. David Sass is here to tell us about primary hyperoxaluria. David, I'll pass it to you.
Thanks, everyone. I hope you can hear me. I'm going to be talking a little bit about primary hyperoxaluria, which is a great example of a rare kidney stone disease, and really a good example of the challenges we face in any rare disease research and clinical care. So these are my disclosures you see here. And by the way, before I even jump in, just to piggyback off the last discussion about urology versus nephrology. So urologists and nephrologists work together, but we have skill sets. Urologists are surgeons primarily who do surgery on the urinary tract and kidneys, among other things, whereas nephrologists are medical doctors. So for me, I studied pediatrics for 3 years before studying nephrology. For an adult nephrologist like Dr. Liskey, he did internal medicine before he did nephrology. So urology is surgical, and they can handle the acute stone events, and nephrology is the medical. We handle things like prevention and figuring out the underlying diagnosis. So there's roles for both of us, and we should play nicely together. And so fortunately, in my experience, we do. All right, so you guys see my disclosures. Next slide, please. All right, so we're going to be talking about primary hyperoxaluria. We'll be referring to it as pH, and talk about how pH results in high urinary oxalate excretion, which then can result in kidney disease and other problems in other organ systems, and then talk about how we manage pH. Next, please. All right, so this is a diagram that I'm going to use to explain hyperoxaluria and where it comes from. So oxalate is a molecule that we get both from our diet, from the food we eat, but also our body generates it endogenously. So endogenously means the body makes it inside by itself. So on the left side of the diagram, we'll start with enteric hyperoxaluria. So that can come from one of two places. So either you have a high oxalate diet, so there are certain foods that have a lot of oxalate in them, and certain foods that have very little. If you eat a lot of high oxalate foods, then your intestines absorb it, and the only way for it to leave the body is through the kidneys. So that can lead to hyperoxaluria, high oxalate in the urine. Additionally, there are certain medical conditions that lead to increased absorption of oxalate from the diet. So in this case, you may be eating a totally normal and acceptable amount of oxalate, but there's something about your intestines that make you absorb much more than the average person. And that oxalate also ends up in the urine, right? So you have hyperoxaluria in that condition. And both of those, you can get kidney stones from the high oxalate in the urine, and maybe a condition called nephrocalcinosis, where the kidney tissue itself calcifies. Then going on to the other side, to that yellow box there are also genetic variants that lead to increased production of oxalate. So this is not coming from the outside. It has nothing to do with your diet. It has to do with your genetic background, right? And so people with this condition, it's actually an abnormality in the liver. And there's an enzyme in the liver that just cranks out oxalate like crazy, and that can lead to hyperoxaluria. So let's go to the next slide, please. So all right, so primary hyperoxaluria is an inherited genetic inborn error of metabolism. As I mentioned, it's a problem with a liver enzyme leading to massive overproduction of oxalate. This oxalate is excreted through the kidneys, and when you have too much oxalate, you get kidney stone disease and nephrocalcinosis. You lose kidney function, right? That chronic kidney disease that we heard about in the last talk. And in some cases, even total kidney failure, or what we term as end-stage kidney disease, ESKD. So once your kidney function falls below a certain level, your kidneys can no longer excrete all of that oxalate. So guess what? It builds up. It builds up in the blood. And so your oxalate concentration in the blood keeps going higher and higher until it gets to a point where it starts to deposit in all of your tissues. So you start to get oxalate deposits in all of the different tissues, including all of those that I've listed there: bone, heart, eyes. And that's sort of the dreaded complication of primary hyperoxaluria, this deposition of oxalate through the different tissues. Next slide, please. So a little bit of history. Primary hyperoxaluria was first described by a doctor in France in 1925, so it's almost 100 years old. But it wasn't until the 1950s that we started to see more detailed case reports, like the one I've shown here from the Journal of Pediatrics from 1950, which showed a child. You can see these kidneys on that image on the right. Those kidneys are both opened up and showing tons and tons of stones in the kidneys. Next slide, please. So then we figured out, not we, because I wasn't quite born yet, but smart people figured out in the 1960s, hey, wait a minute, there's not just one type of pH, there's actually two types of pH. And they figured out that there are different enzymes and different genetic backgrounds that cause pH1 and pH2, the two different forms. And then in the early 2000s, a third type, pH3, was defined. And that paper I showed there is just an article from 1968 from the New England Journal of Medicine that described these two different genetic forms of pH. And then, as I said, the third one was added on a couple of decades ago. Next slide, please. So this graph here is from a recent paper published by our group here and primarily done by one of our fellows. And it just shows the difference in severity between the three different types of pH. So it's kind of a weird way to think about it, but it's the likelihood of not reaching end-stage kidney disease. And so the gist of this is that you can see the pink line with the steepest descent is for pH1. And it shows that patients with pH1 have the highest risk of reaching end-stage kidney disease, which is not desirable. Then the sort of stair-step one in the middle, that blue line, that's for pH2, showing that it is slightly less severe. And then finally, the nearly straight line at the top is for pH3, which very rarely do those patients reach end-stage kidney disease. Next slide, please. So treatment options for pH, in the first decades of recognition of the condition and treating it, the treatment was not truly curative or definitive. It was really a management of the condition. And so traditionally, we treat our patients with very aggressive water intake, an inhibitor of calcium oxalate crystal formation. So I should have mentioned at the outset that one of the challenges of pH is that patients with pH form calcium oxalate stones. Well, guess what is the most common type of stone amongst all stone formers? Calcium oxalate. So the reason why this is a challenge is it means that the most common stone type may represent this rare disease, or it may not. So teasing out who is likely to have pH versus who just has run-of-the-mill calcium oxalate stones can be challenging. And that's what leads to the delay in diagnosis in many cases. So, but we form these calcium oxalate stones, so we use calcium oxalate crystal inhibitors like potassium citrate. A subset of patients with pH1 will benefit from vitamin B6 supplementation, or also known as pyridoxine. And so people with certain mutations, we say, okay, this one's likely to be sensitive to B6, so this patient should definitely be taking it. But for most patients with pH, they don't respond. So a nephrologist who knows how to look at this properly will determine that. And then the curative treatment is a combined liver and kidney transplant, which obviously is a huge surgery and means a lifetime of immunosuppression, so not something we take lightly. And then on the right side, we have a couple of the earlier attempts at development of novel treatments. So first was this bacteria called Oxalobacter formigenes. It's a bacteria that actually eats oxalate, okay? And so people have been trying to figure out how can we put more Oxalobacter formigenes in people's intestines so that it gobbles up all that extra oxalate. And the results have been kind of disappointing, but it's something that's still being worked on. It's an angle that's still being investigated. And then there's also been people who've been looking at enzyme replacement therapy. So there's an enzyme called oxalate decarboxylase that breaks down oxalate, and that's also been studied. Next slide, please. So meanwhile, while all this is going on in the first number of decades that we've known about pH, there was a lab in Germany that came up with this paper that was in a very prestigious journal, but would have been missed by 99.999% of doctors because it's very sort of basic science-y, and it talked about these siRNA molecules that they developed. And so what the authors said in this very basic science paper done on cultured mammalian cells was you can see in their abstract, they said, therefore, these duplexes provide a new tool for studying gene function in mammalian cells and may eventually be used as a gene-specific therapeutic. Go to the next slide, please. So that was sort of the genesis of it. And then for the next 20 years, there was a lot of intense research in this field. Next one, please. And it resulted in the compound we're interested in called lumasiran. So after years of study, it was determined that lumasiran may be useful in reducing oxalate production. So this diagram, I know this is kind of in the weeds, basic science-y, but just to show you, in panel A, you've got a healthy person. And you can see right in the middle of that blue rectangle is glyoxylate. And glyoxylate is sort of the source for oxalate. And so you can see if you follow that pathway down, you see that glyoxylate eventually gets converted into oxalate. So that's normal. And we have these enzymes that give us a normal amount of oxalate and a normal amount of all these other things that our bodies, our kidneys can handle just fine. All right. Now in pH1, you've got this defect indicated by the number 1 there with the X through that AGT. So that AGT enzyme is primarily responsible for preventing too much oxalate from forming. And when that enzyme is broken, as is the case in pH1, you get this massive oxalate production. Okay, so how does lumasiran work? Well, on panel C there, you can see that it does nothing for the enzyme that's broken. But what it does is it takes a step back and it disrupts the transformation from glycolate to glyoxylate. So by reducing the glyoxylate, you're reducing the substrate that forms oxalate. So you're basically interrupting the formation of oxalate. So the idea is that lumasiran will reduce oxalate production. Next slide, please. So this led to years and years of study in patients, and the seminal study that was published in the New England Journal of Medicine that you see here showed this panel on the right side there is the sort of take-home message. So what this showed is that lumasiran indeed reduced the amount of oxalate in the urine, which we believe should be helpful for helping kidneys survive over the long term, reducing the number of stones that form, and protecting pH1 patients overall. Next slide, please. So this was just a later paper that we published specifically on small children, showing the same benefit, essentially, that lumasiran does indeed reduce urine oxalate. Next, please. So lumasiran was FDA approved to reduce urinary oxalate in patients with pH1, but that's not the end of the story, of course. So while we're getting as many patients with pH1 on this medication because it's helpful, there are others in the pipeline. And so this is not an exhaustive list. This is just ones that I'm aware of off the top of my head. And as you can see here, I listed the sort of different approaches that they're taking. And this is exciting, right? So while nedosiran uses a very similar siRNA technology as lumasiran, you've got all these other small molecules. You've got gene editing, enzyme replacement, engineered probiotics. So all these different angles, which is exciting because it may be that the optimal treatment is using a number of these different medications to really bring that oxalate down into a truly harmless range. But this is all work that's being done, and we don't have the answers yet, but we'll get there. Next slide, please. All right, so even though we have this breakthrough medication, this absolutely fantastic mechanism and how it works and everything, but there are still many unanswered questions. So first of all, can lumasiran or any of these other novel treatments slow the decline in kidney function? So GFR is how we talk about kidney function. And really that's, one of the most feared complications of pH is kidney failure. So we don't know yet, we don't have the studies yet to say that lumasiran slows it down, this decline in kidney function. We think it will, it should, but science is not speculation, it's testing a hypothesis and answering the question. So that's still TBD. Then the second question, from a patient standpoint, they really want to know, can I back off on these other things I've been doing? I've spent my entire life drinking, 2 gallons of water a day. Can I back off on that, please? Can I back off on my potassium citrate? We don't know yet. So far, my clinical practice has been to not back off on any of those things until we know more. Then finally, can these emerging novel treatments work synergistically? So that's what I was alluding to a moment ago. Is the ideal treatment, oxalate decarboxylase enzyme replacement plus siRNA, lumasiran, plus a probiotic that's engineered to decrease oxalate? We don't know that. That's going to be years in the future for us to figure out. But it's exciting that we have any options. Next, please. All right, key takeaways. So stone formers should have a complete evaluation, including a 24-hour urine collection, especially children. And for calcium oxalate stone formers, we really need to look for hyperoxaluria. And if we find hyperoxaluria, that should trigger evaluation for the source of hyperoxaluria. Is this a form of pH that we could be treating with lumasiran or one of the newer drugs once they come out? Is it enteric? So amongst all of these calcium oxalate stone formers, and there are thousands and thousands and thousands of them, it's really important that we do due diligence to identify the ones who may have pH. We talked about some of the novel therapies that are emerging, and that when pH is diagnosed, lumasiran should be considered as a treatment, as it is the only FDA-approved treatment for PH1. Will the newer medications be even better? We don't know yet. And will some combination of these newer medications give us a truly perfect treatment? So next slide, please. Yep, I believe that's all I have for you. So these are some of my colleagues who I work with and who teach me everything I know. And I'm so happy to have learned from them and be working with them. And I really am so happy that my patients have allowed me to learn so much. And I really enjoy those relationships too. They are the core of all of this. That's everything I've got. Happy to entertain any questions.
Thanks, Dr. Sass. Just one question, and then we'll move on to Jamie. But you mentioned kidney liver transplant as being, before there were these medication therapies. Does pH usually come back after those transplants happen?
No, so it's a great question, because as long as you do the liver transplant for PH1, you do not get recurrence. That is curative of the disease. Now, there are the great tragedy is when PH1 has not been diagnosed in a patient with kidney failure, so they don't know why they're doing a kidney transplant. They do a kidney transplant, then the kidney transplant fails, and it's because there was undiagnosed pH, and they should have taken out the liver and replaced it with a healthy liver. But liver transplant is curative for PH1.
Great, thank you so much. Well, I want to now talk a little bit about PH2, and I'm going to bring in Jamie. She is a parent of 2 sons with primary hyperoxaluria type 2. And Jamie, I'd love to invite you to tell your story.
Awesome. Thank you so much, and thank you for having me today. For this quick slide, I just wanted to put a face with this disease. So my children, I have 4 of them. My oldest 2 are unaffected, but my youngest 2 both were diagnosed with primary hyperoxaluria type 2. So Alex is currently 18 years old. He was diagnosed when he was 6. He hasn't needed any surgeries, but he does have current stones. So he has 2 stones at the moment, 10 millimeter and a 6 millimeter, which are very large stones. He's a sophomore, getting ready to start a sophomore year in college. So moving from pediatric care to adult care has been a little bit interesting. And my youngest son, Gunnar, is 14. He was diagnosed at 17 months old. He did have to have a liver biopsy, and that kind of led to Alex's diagnosis at the same time. The current stones for him are very small. He has 2 3-millimeter stones. He's moving on to be a freshman in high school. And as a caregiver, I have been helping both these boys kind of transition into helping with their own care and getting to understand their disease, and that it will be with them for the rest of their life. Next slide, please. So I put together a quick overview of kind of our journey with primary hyperoxaluria. It's been about 13 years now that we've had to deal with this disease and learn as much as we could about it. February of 2009, Gunnar was admitted into a hospital. We didn't know at the time that what we thought was norovirus was going to end up being PH. We found out at that hospital visit that both his kidneys were completely filled with kidney stones, some so large for a 17-month-old that he was going to require surgery. Over the next 6 months, we traveled through a diagnosis journey. We were in touch with the Mayo Clinic pretty quickly because none of the doctors in our area at the time had ever seen anything like this. So Gunnar did go through a couple of surgeries, some liver biopsy to check for pH. And he also had, because of his issues, our whole family had some blood work done to kind of diagnose if this was a genetic disorder. The mutation they found in my boys was brand new that had never been seen before through the Mayo Clinic. So getting as much information as we could and scouring the internet at the time was kind of our way to cope and figure out what this disease was and what it meant for our boys. And that's when we discovered OHF, the Oxalosis and Hyperoxaluria Foundation, and you guys will get to hear some more about that here shortly. Treatment for us, we obviously see nephrology and urology. You've heard that a few times on this broadcast. They have daily supplements that they take as far as medication is concerned, mostly just to keep their urine at the right pH level. We also have a large water intake, a lot of water drinking in this house. My son Gunnar has had a G-tube at a time when he was a lot smaller and couldn't take a lot of water in by mouth. Again, a lot of surgeries and blood work and urine analysis, ultrasounds. It's pretty constant. And then, of course, the one thing I always put in my treatment statement is that we were a military family, so having to bounce around to different states and find different care in both nephrology and urology and having those specialists at hand for the boys because of the amount of stone cases that they've had over the years has been quite taxing on us. And then I like to talk about understanding and adjusting to life. I've talked with a lot of families over the years, just from a parent to parent perspective. And it was really hard in the beginning to understand why. In addition to having to find resources and being able to talk to people, understanding that this isn't going away, that our kids are going to be affected and it's not something that there's a quick fix for. Getting counseling for my boys just to make sure that they have someone to talk to. It's not always easy being that kid with a rare disease and having to do extra things outside of their normal routine. So counseling has been a big part of our understanding. And obviously that transition to adult care. I now have one PH2 patient that's an 18, almost 19-year-old, and he has taken a lot more responsibility in regards to his medication and some of the testing and appointments that he has to follow. School precautions is a huge one for adjusting for life. Most of these kids are, the ones that I've known have gotten diagnosed at a younger age. So moving into school and having to drink 2 to 3 liters of water a day, making sure they have bathroom breaks when they need them, that if there's any type of pain that I'm getting a phone call. So using a 504 plan if your state has that. Having extra time to plan and make sure that if we're traveling, we know where the closest emergency room is or that we have our doctor on speed dial to be able to get some assistance if needed. The boys have had sports impacts and social impacts, and of course being flexible. And then the last piece, I am a parent advisor for the OHF Foundation, and I will just tell you that I absolutely love advocating. At first, I didn't want anybody to know. I didn't want to talk about it, but I will tell you that it is really important, and I'm very glad over the last 13 years that I've been able to share my story and to help my kids understand that although they have a rare disease, they are very special, and that they are helping so many more patients with what they are doing in regards to their appointments and their testing and whatnot. So, getting involved, advocating, getting your voice out there, it is definitely something that is going to help my kids and the future of PH. So that is my last slide. So I will go back. And if there's any questions for me, I'd love to answer them.
Jamie, I'd love to, you talked kind of about having your kids and explaining it to them, they have a chronic disease and they're special. How did that conversation go, and what are some tips you have for other parents trying to make that same conversation?
So I got asked this the other day, and I find it really interesting. So Gunnar, of course, was very small when he was diagnosed with this disease. So we used coloring books. We used any type of fun material we could to show him what was going on with his body, to keep him in the loop. Obviously, as a 2-year-old, 3-year-old, he wasn't understanding at the time. But now moving into his teenage years, he can articulate what his disease is. He knows when the pain occurs, what's going on. He knows the medications he needs to take on a daily basis. So I think depending on age, and obviously with all the new materials out there now, there's a lot of ways to keep your kids in the loop and keep them updated on this disease.
Great. Well, thank you very much, Jamie. I also want to bring our final guest on, who is Kim Hollander, and I'm going to ask her to talk about a great partner of the American Kidney Fund, OHF. Kim?
1989 by families just like Jamie's who were confused and didn't know where to turn to. Their children all had primary hyperoxaluria. What started around a kitchen table evolved into a global organization working around the clock to find treatments and ultimately a cure for all forms of hyperoxaluria. Today, OHF is a global leader, a partner, an alliance, and a movement, striving to amplify the patient voice every step of the way. We bring together thousands of people around the globe to join forces to improve lives and advance towards a cure. Next slide. So Dr. Sass did a wonderful job breaking down what is hyperoxaluria. Too much oxalate in the urine. And a lot of people have this. We get it through our diet, as Dr. Sass explained. So if we eat a lot of oxalate in spinach and things of that nature, sometimes we can have elevated oxalate. Most of us can get rid of that oxalate, but people with hyperoxaluria struggle. And so that's where we have to dig deeper and find out, is it hyperoxaluria that you have that's causing your kidney stones? And then what does that look like? Is it enteric, which is a non-genetic form, or actually primary, which comes from within, and that is the genetic form? Next slide. So OHF, what are we? What do we do? Well, we wear a lot of hats every single day. We're a small but mighty organization. We talk to regulatory agencies to try to get drugs to approval. We actually were instrumental in providing the research tools so that different companies are allowed to produce medicines. And we work very closely with biotech to advance science so that we could develop new treatments for our families. We're at the core. So we work with patients and caregivers. We're the patient advocates on Capitol Hill promoting this disease and trying to bring awareness and attention to make this ultra-rare disease much more in everyone's world so that they can get early diagnosis and get to treatment and have a successful life. Next slide. Why do we do it? Well, Jamie is one of our gold star patient advocates. And Lily, who I met a few years ago, really inspired us. Every day I look at our patients and they are ambassadors, they are survivors, they are superheroes that have to deal not with 1 or 2 kidney stones, but hundreds in their lifetime. And that's not okay. We need to come together and make a difference. We need everyone in the PH community and the EH community to stand up and make that change. Join us together with OHF and let's make a big difference. We partner with places like American Kidney Fund, and we bring these webinars to you to try to bring awareness around kidney stones and help you get the answers. If it's not PH or EH, could it be dense disease, cystinuria? And we really need to dive in and work with your nephrologist to look at that underlying condition of what really is behind your kidney stone. Let's get those answers. If you'd like, visit us at ohf.org. We're here to answer any of your questions, and we wish you nothing but success on your journey to finding your answers. Thank you.
Thank you so much, Kim. I really appreciate you being here, and we appreciate the partnership with OHF. That's been so great. Well, we only have a few minutes left. I've got time for maybe 1 or 2 questions. I do have one that I'm going to pose to Dr. Liskey, and again, you can see on your screen there is a way to continue to send us those questions. Dr. Liskey, we had a question from the audience just regarding kidney stones, frequent kidney stones, and the chance or the correlation, the relationship of developing CKD or kidney failure? Is there a relationship, and what does that look like?
And so there is certainly, we've studied that. So if you do have kidney stones, there is a slightly overall increased risk of chronic kidney disease. I would say in most patients, it's not the biggest deal, but in these rare genetic diseases we're talking about today, those are the people that are really at very high risk for kidney damage. So it's something to keep an eye on, but I think that for most people, CKD is not the biggest part of their kidney stones.
Great. Dr. Sass, anything to add to that answer?
Nope, you nailed it.
Okay, great. Well, we only have a few minutes left, and because I want to give all of the four of you a chance to just give any some final thoughts. I mean, what are some? You mentioned some key takeaways in your slide, but for those watching that are suffering from stones like Leanne was, and frequent stones and the pain and the confusion around it, I'd love to just get your final thoughts. And Dr. Sass, I'll start with you.
Yeah, so I would just really encourage people to seek expertise, right? So if I really get discouraged when I hear about patients who, are passing stone after stone after stone and having surgical procedure after surgical procedure, and it's never introduced to them that, hey, there may be a way to prevent this. There may be something we could be doing better. Maybe you should see a true stone expert. So I would really encourage patients to advocate for themselves and find out who the experts are. Ask your doctors. It's not that hard to identify experts in the field. So I really do think that there is a benefit to seeking true expertise.
Okay. Jamie, how about I go to you next? What are some final thoughts you want to leave with the audience?
Yeah, I think my biggest thing is just ask questions, ask to understand. If you're dealing with this, or if your children are dealing with this, you are essentially their advocate. You're the one that's going to have to tell that story over and over. So seek to understand, find as many resources as you can. The OHF is a great place to go when you're looking for resources on this disease.
Okay, great. Dr. Liskey, how about I go to you next?
Yep, I would actually kind of echo what Dr. Sass said, that I would seek some expertise if you're having this, especially if it's something that's causing you a lot of problems. Even though it's terribly common, kidney stones, I would say the number of people that are interested in this and would do the right workup isn't as common. So if you're not getting the right answers, ask to be sent somewhere where somebody is actually interested in trying to prevent kidney stones.
Great. And Leanne, you get the final thought.
I will kind of reiterate what the doctors have said. If you don't feel like something's giving you the right answers or you want more, go to the internet. Go wherever it tells you that you will be able to find more answers than what you are. Don't ever just take one answer. Go on, find the experts. In fact, I just got a little bit of a hint there from Dr. Sass. I'm going to look into a specialist that can really can't even talk today, dissect what these stones are made of so that I can maybe make my future a little bit less painful.
Thank you, Leanne. That's a really great point. And that's really the beauty of an event like Kidney Action Week and having these sessions, is hearing these stories and then taking action like you're just planning on doing. So I really appreciate everyone on the panel today for your patience, your expertise, in talking to all of our audience members about kidney stones. Bring up our final slide. And if you suffer from kidney stones, as Leanne mentioned, it's important to get accurate resources. And we are in the process of building more of those. So if you suffer from recurrent kidney stones, we'd love to hear from you. You can email us at education@kidneyfund.org, and we'll keep you updated when new kidney stone resources become available. We've already got some great ones on the website now, especially around pH that we've done in partnership with OHF, but we're with more to come. And if you aren't already, please follow us on Facebook or send us your email through kidneyfund.org, and you'll be on the first to know about other resources like Kidney Action Week.